submitted material essentially analyzes the glaring inconsistencies in pre-procedural robotic surgery curricula worldwide. It really does dive deep into that. Yeah, so let's jump right into the feedback. As I understand it from the notes, the whole argument here is that we urgently need standardized simulation training, right? That is the overarching theme, yeah. The material effectively presents the statistical disparities in simulation training, but it misses a really big opportunity to deeply engage clinical surgery trainees by centering their lived experiences. Okay, so it's missing that human element. Exactly. The weakness is that the data, like the fact that wet lab access drops to just 22% for junior residents, is stated entirely objectively. It reads a bit too much like a textbook, you know? Wow, only 22%. Right, it's startling. But written this way, it loses the practical emotional stakes for the trainees who are actually facing those educational gaps every day. So how do we fix that? Because just dropping stats usually doesn't stick with the reader. Well, the suggestion is to frame these findings directly around the trainee's clinical journey. We need to highlight the urgent importance of standardized simulation training in a way that resonates, like putting the reader in their shoes. Give me a concrete example. Sure. So instead of just stating that 22% statistic, visualize it for the reader. Picture a resident stepping up to a live patient console, having only ever practiced on plastic models. Oh man, that is a terrifying scenario. It really is. And we should explicitly urge trainees to advocate for wet lab time and non-technical skill drills, like having a circulator nurse role play a fire alarm while they're sitting at the console. Right. But I actually have to push back on that just a little bit. Oh, go ahead. Because if empowering trainees is like training the pilots, medical educators are basically the airline executives. How does material speak to them? Because a junior resident has zero leverage to just demand a fire alarm role play. That is a completely fair point, and it brings us right to our second critique. The analysis correctly identifies the lack of standardized simulation training, yet it stops short of outlining a concrete advocacy roadmap for medical educators. So it's keeping things a bit too high level. Exactly. The weakness here is that it presents this proposed generic framework as a purely theoretical solution. It doesn't actually give educators actionable steps to overcome real-world barriers. Like the cost, I'm guessing? I saw a $2,200 per trainee cost mentioned. Yeah, that's one of the biggest hurdles. It cites that cost, but then just parks the car right in front of the roadblock. So my suggestion is to bridge that gap between the theoretical framework and practical implementation for the educators actually building these programs. So give them the tools to fight for it. What's a concrete example of that? Arm educators with the business case. You contrast the $100,000 cost of a simulator with, say, a $2 million robot investment. Oh, suddenly the simulator looks like a rounding error. Exactly. And you also contrast it with the catastrophic cost of a lawsuit. Then you recommend they build modular, proficiency-based programs using existing virtual reality time. Rather than relying on those vendor-provided weekend courses. Right, because those are usually just for experienced surgeons anyway, not novices. Makes total sense. So to quickly recap, the two main points are framing the statistics around the trainee's lived experience and then providing a concrete implementation roadmap for medical educators. You nailed it. And we really invite the listener to implement these actionable suggestions and submit their revised work for another critique. It was based on the most recent review by Dr. Reza Lankarani, general surgeon, founder, Surgical Pioneering newsletter and podcast series, editorial board member, Genesis Journal of Surgery and Medicine, surgical consultant, AIGENELAB. To access additional details, please refer to the Surgical Pioneering podcast series application available at the following link, https://surgicalpioneer.codex.me. Because ultimately, if we demand our pilots know exactly how to react in an emergency, we should demand the exact same preparation before a robot ever touches a patient.